Today we're covering mitral valve prolapse. On the left, you see a normal mitral valve, slight prolapse, but mostly normal. On the right, prolapse. These are two valves where this one is slightly prolapsing on the left, and on the right, no prolapse.
So we call it MVP. So sometimes it's associated with skeletal abnormalities such as pectus excavatum and pectus carinatum. And the excavatum is a hollow-shaped chest wall. So this is pectus excavatum. And pectus carinatum is when the chest wall protrudes outward. So that's this right here. So by the way, these people have amazing echo images because you can just put the probe into the indentation and you see the heart much better. So for mitral valve prolapse, it's where the anterior mitral valve leaflet or the posterior mitral valve leaflet prolapses beyond the mitral valve annulus back into the left atrium during systole. So the murmur that we're going to hear is a mid-systolic click with or without a systolic murmur. So some of the causes, the main one is unknown. It can be hereditary. It can happen to women under the age of 40. It can be a connective tissue disorder cause, like Marfan syndrome or Ehlers-Danlos. Just know that they're both connective tissue disorders for now. We will talk a bit later. If a person has an atrial septal defect or a ventricular septal defect, that can happen. It could be associated with any type of skeletal abnormalities like scoliosis. And a person could have a false positive mitral valve prolapse if the sonographer doesn't have a good window. Make sure that you're not shortening the valves. Make sure that you get a good window all the time. And you always want to evaluate other valves. Because sometimes if a person has mitral valve prolapse, they may have tricuspid valve prolapse as well. So in 2D, this is what we're going to see. So if a person has mitral valve prolapse, a lot of times they don't even know they have it. So some, if they do have it, they may have an atypical chest pain, dizziness, irregular heart rhythms, or syncope. And it could be a progressive situation. By the way, if a person has mitral valve prolapse, it increases their risk of developing infective endocarditis. It can cause a rupture in the chordae tendineae or papillary muscles. It can cause an increase in a person having like an embolism and sudden death, but that's very rare. So if the person is asymptomatic, they don't need treatment. If they have mitral valve prolapse and mitral regurgitation without symptoms, the doctor is just going to monitor them. If they have symptoms and their mitral valve prolapse is bad, they're going to want to give them medications or even offer to repair their valves if they have mitral regurgitation or chest pain or they're losing consciousness. They're going to want to repair that. If they have mitral valve prolapse plus significant mitral regurgitation, they'll put them on medication, repair their valves, or replace the valve completely. So you do not diagnose mitral valve just from the forechamber. In plaques is where we actually do it. And we're going to direct your attention to this image right here. We're going to draw an imaginary line from here to here. Then when you're actually measuring it, you're actually going to draw a line from this annulus right here all the way to the posterior annulus. And you're going to draw a secondary line. This is systole, by the way. Notice the valve is prolapsing back into the left atrium. You'll draw a line from here to here and from here to here. If those lines are greater than 2 millimeters, it means the person does have mitral valve prolapse. So this is what it looks like in echo. The valve prolapses back in during systole. So in parasternal long axis, that's our best view, and that's where we measure it. We are going to want to evaluate all views. We always want to make sure that it's actually prolapse. Remember, if it's greater than 2 millimeters, then the person does have prolapse. It has to go past the annulus, and we draw this line, measure from here to here, measure from here to here. If it's less than 2 millimeters, we cannot call it prolapse. Again, do not diagnose prolapse just from the forechamber, because in a normal person, in the forechamber, it can look like it prolapses just from us looking at the forechamber by itself. So in M mode, we're going to be looking at these. Remember, it happens in systole, so when the valve is closed. So we can have a mid to late systolic prolapse, that's that greater than 2 millimeters below the C and D point. Or you can have a hollow systolic prolapse, that's that 3 millimeters below the C and D point. So just keep that in mind. This image, right, your first image right here is showing you mid to late mitral valve prolapse. And the second image is showing you that hollow systolic mitral valve prolapse. Just keep that in mind. All right, you guys. So we're going to use color flow Doppler. So we want to check the prolapses. And the flow is going to move in the opposite direction of where the prolapse is actually happening. So if you have your posterior directed MR, it means that the person has an anterior mitral valve prolapse. If you have an anterior directed regurgitation, it means that it's the posterior mitral valve leaflet that is prolapsing. So the flow is going to go the opposite way from the valve that's actually causing the prolapse. So I want us to go ahead and watch this. It's going to help you guys understand more.
What we see here is the peristernal long axis view, and the patient has posterior mitral valve prolapse. This is most likely going to cause the patient to have regurgitation with the jet moving anteriorly. I'll show you this in a moment. Many people don't know they have it because the signs can be subtle, different in every person, and easy to overlook. Remember to measure the severity whenever you see it. This other patient right here has Marfan syndrome, and what you're going to notice is the two most common signs, which is the dilated aortic root and also mitral valve prolapse. So what happens is generally these people, if they're not monitored, they're going to have aortic dissections, and that could potentially kill them. Unfortunately, those with Marfan syndrome end up having stretchy vessels and joints, so it makes them much more prone to injury, especially for the vessels as the blood moves through over time. Remember, it can affect the heart, eyes, and skeleton. So what you're seeing here is color flow Doppler for that same patient with Marfan syndrome. In this case, the anterior leaflet is prolapsing more, which is why the jet is moving posteriorly, because the anterior leaflet is prolapsing more into the left atrium than the posterior one. Look at the amount of regurgitation that this patient has. This is why it's important to monitor those with connective tissue disorders, because it can literally create other dangerous heart conditions for those people. This is a side-by-side comparison of a patient that has anterior mitral valve prolapse. So what you're noticing is when you turn on the color Doppler, the jet is going to be angled posteriorly or moving posteriorly because the anterior leaflet is prolapsing more. Always remember, the jet direction is always going to be moving in an opposite direction to the valve or leaflet that is prolapsing the most. Marfan syndrome comes from changes in the FBN1 gene. For this next image, what you notice is that both of the anterior and the posterior leaflet are prolapsing almost equally. So what is happening is the jet won't be moving anteriorly or posteriorly. It's going to move centrally more towards the back of the left atrium because both of the valves are prolapsing almost equally. If this helped you, subscribe so I can keep helping. Don't miss the next video.